Madame Minister and honored guest, as we have just heard from Fabien, we talk about prevention. Sometimes we have the impression that prevention will be the remedy for all the different illnesses in the health area. The aim today is not to have a theoretical academic topic, no, but rather we would like to look at how we can have prevention measures done concretely, by whom, which professions, and how. So I'm going to start with Madame Minister, Madame Agnès BUZYN. We're very pleased to welcome you here at the roundtable of CHAM. You are the best in position to really start this debate and talk about the word prevention. What does it inspire to you? And how can we now, with the actual context, how can we do prevention, with what resources, which personnel, which skills? So thank you very much for this invitation at CHAM. I would like to thank Guy for this invitation. I'm sorry I couldn't be here today. I had an important meeting this evening in Paris. Prevention is a very powerful word, and at the same time, what we have prevention, it really depends on from one person to the other. When we talk about prevention, my ideas have really evolved because I had different functions that I took up, and today I would like to tell you my vision today about prevention. I have developed this in recent years by working on the different with WHO work, and I've seen how prevention was difficult to set up in different countries, even when you have goodwill. We have people around the table that I've worked with. For example, Anne-Laure, when she was the director of communication at Malakoff, I worked with all the different prevention campaigns against alcohol, tobacco, and different screening of cancer, and also the director of IRS, who is here. And I saw the limits what the medical world can do when you have the passage to act in prevention. I want to say that around this table today, we don't have the main actors here in prevention. We really want to be useful. We have to really act on the food, nutrition, people that don't have physical activities, addictions. To do that, we have to have the different heads of companies, the educational institutions, the different territorial bodies, and the mayors. They are the ones who set up the transportation policy and also the food policies in school cafeterias. So as of a young age, we already need to adapt the favorable behavior good for health. So a lot, what French people know, you need to walk, you need to do sports. We know this in France, and it's very good for health. However, when you ask them, they all have this information in their mind, but it's really hard for them to really do this, to walk when you have cities and you have these sidewalks that are not in good shape, or when you have a lot of stairs and you're an older person, then to really take up these physical activities, it's really hard to do this. And even take up sports activities, hard to really do this. Today, I'm convinced that if we want to be useful in the prevention area, we should stop medicalizing prevention. I think the medical area has come up to what they can do in terms of communication. Screening, for example, we could always do better in screening. We can have we can target the risk population, for example. And so we have prevention, public policy, if they're primary or secondary, and it's based on risk factors. But if we really want to be efficient, to really ensure that people age well in good health, and I think today the dependence, loss of autonomy is really linked to chronic illnesses. If you aren't sick, if people don't have a chronic illness when they're aging, they won't become dependent before 95. So if you want to age well collectively and reduce this problem of autonomy, we need to really have policies that are interministerial intersectorial, where all of the public actors take up their tasks. The Minister of Health is the person who is not really in the best position to be efficient in prevention. Of course, we've done a lot in the area of screening, et cetera, et cetera. I want to launch this action saying, we talk about prevention, but now we've failed because those who really can set up prevention are not here today. Thank you very much. So I'm sure this will trigger off reactions. And our Danish friends who confirm the responsibility of health for citizens, they have set up this. And this led to have a primary frontline health area. So we looked at this Danish example today, and we can be inspired from that. Now, before we come there, I would like to ask Madame de BORT, who's from the Regional Health Authority, as we said, from ARS, and she has specific conditions to really have a health coverage of her population. And we're going to talk more about that. We'd like to know, how can this ARS, Regional Health Authority, how can they set up and get out of just a health area? How can they also work in the social area? How do we do this concretely? With what efficiency and what skills? New skills even are involved in this. Thank you very much, Madame Minister. I agree with what you have just said, Madame Minister. I have the pleasure of starting to compare in these two regions of France, the Guyana and also the Centre-Val de Loire, and they have weaknesses and strengths that are different and complementary in the area of prevention. Now, the Guyana is twice as large as the Centre-Val de Loire. We have one single department, so we have this organization, which is easier. 22 mayors compared to. So we 1,700 here, or mayors. So you can see the difference in action. Now, in the metropolitan area, I have the pleasure of observing that there are elected officials that are mobilizing their community for urbanization programs that are favorable for prevention. So we have special preventions. We have initiatives from the collectors in favor of urbanization, which is good for health. In Guyana, we have other strengths because of the past of this territory, especially in the area of infectious illnesses. We have developed in Guyana, as in these other territories similar. We have this job for the health officials. We don't have enough of these health actors like we have in Guyana. Why are they missing? I worked with a special in the metropolitan, we could not find them. Why? Yes, we have doctors, we have nurses, we have fantastic people, but we don't have this mediators. This is important for the curative and the preventive. We have different persons depending on their references, their cultural references, what they've understood, what they can do. And I visited this health center in Rio de Janeiro in Brazil. They're more advanced in terms of questions of the health, primary recourse health. They said the team, they're going towards this special health center in Rio de Janeiro. This is all around the slums area. And the team is 1 doctor, 2 nurses, and the 6 mediators. And so you get this idea of this approach of health there and the professionals. And you have training, which are free, and they're provided to these persons at the slum areas. There are different people who want to become mediators in the slums. And so we tried in Guyana to also develop this. We created this mediation, DU, mediation unit, and we don't have this here in France. We don't have this kind of in the metropolitan France. We don't have, so we don't have any titles for them. It's not a problem of funding. No, it's not a problem of funding. It's really training is important, recognition, and maybe not statutory. Maybe you don't need a diploma. Maybe they don't have to have a high school diploma, for example. If we'll be adding lots of years, we don't have to do this. This is done. This DU is at the university. It's co-financed by the ARS, and it's even without a high school diploma. It's really what do we look at the criteria of motivation and their professional program. So it can be a medical secretary, it can be a nurse, but also it can be a mother, it can be a head a chief of as well. We've done things in this territory which is not as well equipped in transportation and etc. And I do remember there was a signal when we have in a slum of Cayenne. Immediately, everybody was mobilized. The animal health, human health, because you have to really not work in a dispersed area. In Metropole, we are dispersed, but you have the health mediator, Red Cross, Pasteur Institute. You have epidemiologists. They're catching in traps these mice, and we do the serological survey, which we can't do if we don't have the mediators. And we restitute all of this to the population, communicate to the population. So very concretely, that means into rethinking of our health area is to have a health mediator to really take up this task. So the roundtable already has achieved its first aim for CHAM 2024. We, in this territorial approach, is another approach, which is a population one, the aging population, to age well. Everyone talks about that. And you are the reference in the area of the different studies in aging. You had the first teaching university hospital. We'll also talk about the ECOP program as well. But today, and this morning, we're talking about demographic tsunami, which will be really coming up. How do we handle these persons in a preventive way? So is there not, first of all, a problem of human resources that are competent, that are adapted to really structure all of this? So is there a shortage of this kind of manpower? Is this not just a problem of skills? Yes, we have to adapt our health system to the aging. We'll be spending 30% of our life after 60 years, and our society was never confronted before with this phenomenon. I talk about phenomenon because maybe it's really an opportunity if aging is done well. But if it's done massively, on the other hand, with dependency, then it will be a disaster. We need to adapt our health system. Rather than going to dependency, we have to talk about aging well. What does that mean? Everyone talks about it, but we have different definitions now. We have the definition from the WHO. To age well is to be autonomous, to keep our functions, to do what's important for each one of us. You have someone who's 70 years, 75 years old, they continue doing policy, then they should do that. You have somebody who is 80 years of age, and he wants to continue to save the planet and continue cycling and to see his daughter on the other side of the department. Yes, they should be able to do that. We need to have a health to maintain functions so we can continue what's important for each one of us. Now, how can we adapt our health system? The resources are there, but they're not used efficiently. I'll give you an example. If someone feels fragile, and so if they go see a nurse from the department, say, "Oh, you're not yet dependent," because they come see me in 2 years, she says, when you become dependent. And it's too late then. No, if we consider our health system, because so aging is like a staircase. Whenever at the top, we're robust. Whenever at the bottom, we're dependent. So we have a health system which pushes up, and I'm careful about my wording. We're going to be going quickly down the staircase, and when we're at the bottom, we go to the emergency and then nursing homes. So this is the reality of every day that we see this now. And this is a drama, which is a human one. To become dependent is something terrible. It's a drama which is economically based and also with resources, because we don't have the personnel. How can we ensure that the people aging do not go down the stairs like that? We're working with the National Academy of Medicine. What is reasonable and what is necessary? What is sensible, reasonable, is one to maintain one's body functions. We're lucky to have this special Malakoff from WHO that wants to do this. We have 70,000 programs that with this ICOP program, monitoring program. And the second element, we have to look at the aging pathologies early on to handle them and in advance. Soon at the U.S., we will have these blood markers, which will enable us to see if we produce an abnormal protein, beta 42, which will lead to Alzheimer's disease. So this gives us the perspective to really perceive early on we already have these other therapeutics, oral therapeutics that will help us. So Alzheimer pathway will be just like with cholesterol and cardiovascular pathways. And the third element, which will be the real revolution, is the zero science. What does that mean? Well, aging is the main factor of the different pathologies related to the more we age, we have all these different degenerative issues, et cetera, et cetera. And so what we can do, we have our chronological age, we can modify that. And that's an invention from the society. That means the time we will spend on time, but not the biology related to, now the biology of aging. If it exists, and it does exist, we will soon be able to measure our biological age. There's a lot of investment in that area. In a few years, we will also, from our insurance card, we'll be talking about our real biological age. And we can have people that are 40 years and they have maybe a biological age much of a senior. And when we know all of this, this will give us perspectives for new therapies. When we old, we have these senescence cells, the way we lived, and we have our DNA. These different senescence cells will be in different areas of our body. And now there are different ways to destroy these senescence cells. These pro-inflammatory factors can be reduced. So you can really do something about these pathologies. We've done with the age cells. If we destroy the pancreas senescent cell, then we prevent diabetes. That means the industry that works in the area of the senescence cell, they can continue how make this revolution. Now we're talking about the organization aspects, because in particular, a person who is hospitalized and he's an aged person, they lose their autonomy when they go back to their nursing home. There's lots of questions. You have to organizational issues and skills. We'll talk about that later. We're going to continue going around the table. Anne-Laure, you have in a business area approach. You Malakoff Humanis. Could you tell us what it is? Not everyone knows that Malakoff Humanis. You have this prevention program in different companies, and you also have an economic aspect. We hear a lot about, is there return on investment or not when we have a prevention program? What is your opinion about that? And once again, what organization, what skills are involved? Well, maybe before bounce back what Agnès was saying, and after having spent some 10 professional lives just spending lots of these major public campaigns in France, or also the Cancer Institute in France. Yes, today we see the limits of these major communication campaigns, and today we have to take more structured and structural measures in the area of prevention. We have an approach which is not population, which is really the life where they work. It's their workplace we're talking about. This is a person in the workplace. How can we help them to improve their quality of life? It's true, you're really right to highlight the economic model. It's true that prevention is a major challenge. It's an economic challenge that's major for the health insurers and mutualists that we are, and private funds. But we have this challenge to enable us to act on the risk before it happens. So we should really then do something to prevent all of this and these costs. In fact, when you talk about the economic model, it's difficult to us to measure the impact of our prevention actions on the different health issues in our companies. We know all the benefits of prevention. It's a long-term program. And our clients, we don't keep them 15, 20 years. So we try to work on the technical aspects of our contracts. Often we have in the short term, we're not in the long term. So yes, in fact, that's an important point. RSO is not an image, but yes, what I want to say is that we have our efforts not only mastering our cost and profitability, we also have a real mission. We are protection, non-profit organization. We have a societal responsibility, and our will is to also improve health. And also in this insurance area, we do this. We have professional branches that we work with, And here is where we can set up special prevention programs that are adapted to the specific sector of an activity. When you talk about farming, for example, that's one specific area. And this enables us to have prevention programs that maximize, that are relevant and more efficient. We set up, for example, for the different hotels, restaurants, that we ensure special prevention programs and fighting against alcoholism with different issues that are adapted to this population group. We have other programs for prevention against stress and also related to mental health. We have this our consult and study part of our business also works in that area. All this is very relevant. What's very distinctive in our with the Malakoff Humanis to have a multidisciplinary approach for prevention. We have the medical aspect, of course, and then we have the social aspect. We support those who are insured that are most fragilized. Either we have financial help. These are considerable amounts of money, 100 million euros to help our staff that have encountering difficulties in the social areas. We have psychologists, we have social assistants who are employees of Malakoff Humanis, and they go to the companies to support the staff. So this complementary approach is very important. Medical and social approach enables us to really tackle all the different dimensions of prevention. As Madame BUZYN, because you're remotely there, so you can act at any moment that you want. Unfortunately, you're not here in presence, but would you like to intervene now? Would you like? I'm going to let everyone talk about that. You are the new farming mutual fund, which knows very well this public, which is identified, would have different specific risks. With the Farmers Mutual Insurer, and we have the risk that is known that we know, and so we also you help people in the fields, and this. CCMSA has several decades. Have you created new professions to support the agricultural sector, your farmers? And in fact, how does it function? Already, yes, as you said, we know our population, the agricultural population. We know the different personnel, the farmers, their family. We know the territories where these populations live. And thanks to two major elements, we have this network of elected officials of MSA, which is a special democratic model, and all of the different every 5 years we have elections. Of our elected officials, and there are 14,000, and they're there to really communicate all the different needs of the territories where they are working. And we also have the specific of helping social protection. We are a single window. So this gives us lots of information concerning the health issues, for example, social, family information. We know the professional context, the housing situation, and we know that the different factors related to health is very broad. So this information is important when we want to have preventive activities. You were talking earlier about actions that are done concretely, CCMSA, and we have a pluridisciplinary approach. This mobilizes doctors, nurses, but also ergonomic specialists, psychologists, social workers, people that are experts in prevention. And to give you one single example, and that's what you indicated, we also, in the agriculture, we have this suicidal risk for farmers. And so we have looked at this. We know our population. We know our territories. We have action that we have set up and different measures. We have a different platform that listens 24 hours a day. We have other measures we take. We know in the farming area to leave your farm is very difficult. And so we have set up also these sentinelles. We also with the ARS, the regional health authorities, we have 6,000. These are people like you and me that are close to the agricultural area. We've trained them for a 3-day program so that they can identify and they can see different suicidal risk population, and they can respond to that. That functions very well. We train almost every day, and this shows that prevention is, of course, for the health professionals, but also everyone should be involved, and citizens that are trained, that have this awareness. They can be actors on the local level. Why this know-how of CCMSA, which is almost 30 years, why can't we not roll it out later? And the models exist, and we're looking for things abroad, and we already have them here. It's really for me, so why don't we copy what we have from you? And Madame Minister, would you like to react about this? First, going around the table here, what is your feeling? What is your point of view about what we have just heard, Madame Minister? Yes, first of all, obviously, all of these different initiatives, all these works are essential. When I was voluntarily being controversial earlier, it was not to really minimize this impact that you can have that from the insurers, the different territorial organizations, and different mutualist insurance companies. And you have targeted this population because you have the different territory actors and the mutualist insurers. They understand the risk factors. But today, and this is what I would really like to insist upon, this point, when we have prevention actions, they're too late to have a major impact on the health of population. It's too late. English studies have shown for €1 spent on prevention in the childhood up to 10 years, we would have to have the same impact. You'd have to spend 50 times more. So €50. So if we want to have an impact on the aging of population, have aging in good health, I believe that we need to, collectively, we have to work on this. I think of the mayors. They are the ones who can set up the last mile concerning accessibility, sports structures, storage facilities, collective cafeterias for schools, and also urbanization issues, etc. And they are the ones who can have a prevention policy which is plurisectoral, intersectoral. So my combat today, and it's a combat that many countries have understood. For example, in Africa, they have this special a very pluridisciplinary approach in Africa. We are still we have the old references we're using. We have to put money in prevention. We have to prevention consultations. All of that, of course, is very good. But that it's too late. It's not really major to have an impact on these risk factors. We have to have a holistic approach. All the different actors of society, they have to feel concerned. First of all, you have the mayors, as you said earlier, because they can set up what the public authorities cannot do. They can handle the last mile for accessibility, for good behaviors for health. And I'm really sorry today that you haven't invited this association of the different cities that are promoting health. They are the ones that we really need to make a big leap to have a high-quality public health program. Maybe a reaction? Very quickly, yes. In fact, Madame the Minister, the mayors are essential actors when we locally have a charter for those who we have AIDS. We have charters for them. We have the mayors, we have association, and this is how things function well. And there is another actor for prevention that we should talk about, which is the person itself. If we want to have prevention that's efficient and relevant, we need to ensure that each one is an actor for their own health. To do that, we believe in the special programs. We said special motivational interviews that can be done by nurses. We have to find the person who is far away from a good health pathway. So we, in the short term, we know this has effects on screening, the level of solicitation for screening, and also has an impact on vaccinations. Our hope is that for the long term, this will make the people more autonomous in their health care pathway. So the primary health care, they can be the actors. They have consultations that are offered at the 3 ages of life. Maybe this is a way of detecting situations that could be negative. Not everyone has their own doctors, but when they have their own doctors, maybe in addition to what we heard from Madame Mayor, so these one's own family doctor could really be also, I believe, in a good position to detect these kinds of issues. Now, perhaps we're going to continue. I would like to hear about technology and ECOP because it's essential. If you could, very quickly, a few words about ECOP, because it's a fantastic tool that you've rolled out, and it's organized by WHO. And this is why the technology is very important for this program. To age well is to keep your functions so you can continue to do what is important for each one of us. There are 6 functions we have to maintain, which is what we saw, the sight, the hearing, memory, mobility, nutrition. So WHO has its team working in the different departments of this so that we can have this program of ICOP prevention. What does it mean? I mean, it integrates. We're going to be maintaining all these functions in an integrated fashion because they all react with each other. So this was in 2019. We are staff at WH. We worked on the design of this program, and this program stopped because of COVID. And we, at that time, we were discussing with the DG of ARS, with Madame here, Clara that was here. We said people are locked down, so they could lose their autonomy. So we need to. Now we digitalize because we couldn't have direct contact with these patients. So this ICOP program has 5 steps. The first one is to a simple targeting. We're going to ask you are you capable of getting out of your chair 5 times without using your arms with more than 4 seconds? If you have, otherwise, if you can't, then you'll have a risk of losing your mobility. If you do it, then you can try it, go all the way up to 7 seconds. So that means that in 1 year you have to be at 7 seconds, and 2020 you have to stay at 7 seconds. Another question from WHO. During the last 2 weeks, were you depressed without hope? Or did you lose the desire to do what you like to do? And 30% of the seniors say yes. So how can we age well if we're depressed and we don't have any hope and we don't have a desire to do what we want to do? So we see those who are depressed, and a lot of them feel isolated, and we have to act on that. So one, we have to do the targeting, and we can have participation. We can do this application. 20% of the people, they do this themselves, and then we do this more in-depth evaluation. 10% of the persons to understand why, and then we have an intervention that will be set up. It will be between social and medical. The function is the result of our intrasec capacity in our environment. For example, our sight is a result of our intrasec sights, and also the lighting, and also wearing glasses connected to that. So we always have the social and the medical that we work on, and we have to work on those to age well. And we have to monitor. This is why we use the digital tools are useful for that, so we can monitor alerts, and we have this remote platforms that can act then. And you have to have a favorable ecosystem. That's why we're saying you have to have town halls that can set up all the systems necessary and this is the public authorities can do this. So ICOP is that, and it's developing now in the whole world, and France needs to keep a step ahead in this. If this will favor aging well and avoid dependency, 50% of dependency could actually be prevented, and we could have an action that would be very important. Well, the time is flying, so we're almost getting ready for the conclusion. Would you like to say something? I wanted to react about what Agnès was saying. We see that there are a lot of initiatives, a lot of tools. We saw so many digital tools, artificial intelligence that's emerging in a stronger way. We need, I believe, to have structured policies. We need an organization that aligns all of the different actors, rallies all the different actors together. We need to have a structured major program. This is essential, where all the actors, public, private, associations, professionals in the health area, all of them can really rally together their efforts. That's essential. To talk about the digital tools, as the Madame Minister, what we do, we also have set up this special health reports for different cardiovascular illnesses, for example. We're rolling it out for our whole portfolio. So we have 20,000 tests that were done with special digital tools to enable us to identify risk factors, and we also had then connected with access to a professional health actor and a pharmacy access as well. And then we have orientation to the areas where they can set up more virtuous behaviors. So we have a lot of these initiatives. We need to organize all of that so we can find synergies from with all these different efforts that are being set up and should be set up as well. Very quickly, I wanted to highlight that we finance, not enough, but the different health contracts, because we mobilize mayors. It's through these special health contracts, and where we have also this HR. The mayor alone cannot do things. You need a special local health contract, and these are precarious, poorly paid, They're only for 1-year contracts. So it's very difficult to have these kinds of coordinators for these different health actors, mental health actors that can help these experts. We need to have stability for these kinds of actors for their jobs, and universalization that's proportioned. How can our prevention actions should benefit those who really don't have access? And most of our activities really help those who really don't need it as much, and that's really not the right way to go. So we will give Madame BUZYN the last word, and I also maybe we have different lessons. We're optimistic. There's a lot of things that exist. We're doing a lot. We haven't spoken too much about money. Madame BUZYN, if you were a minister, what would you do to have a public policy? If you're the minister today, this is interministerial. We have all these different bricks. We're really very close to what we need to do. Madame TORRÉSIN, please, the general manager of the agriculture. Well, we need to really have this idea of a global, one single health program. We're in the agriculture area, and we're very close to all these subjects, the interaction between human health and animal and environmental health issues. This is something where we need to go quicker than what we're doing now. Now, Madame the Minister, Madame BUZYN, if you could really put a reflection on all of this. Would you give us a conclusion to construct a public policy? It's possible, feasible. It's not just a question of money. Of course, you need to invest to have results. But we are not far from this. If we could imagine the word prevention is something agitatoire, what is your reaction? Well, and this will be the conclusion. First of all, I really in phase with everything that was said at the round table. What we had from RAMON, we needed structuring. What we also heard about universalization, Clara de BORT will be. We have people that already have an awareness, and if we don't reach those who don't have an awareness, that's not the right way to go. I think we could do better with the money that we are putting out on the table to have efficient policies. What we need, the problem is conceptual. When the Ministry of Health, in fact, well, I understand we haven't really understood. We have to stop thinking that the medical area can alone do prevention. You have the medical aspect, of course, and around the table there's lots of initiatives that are obviously, these initiatives are essential. When we know the genetic factors of illnesses, we can also do early screening, for example. But also, in addition to this, you have prevention, which is related to public policies and a societal aspect. And this prevention, it is not yet understood. Let me give you an example. When we had different parliamentary discussions, permanently you had all these endless debates saying the Minister of Health doesn't have enough money put on prevention. Stop funding these prevention consultations, which will affect those who have the best awareness of the prevention. No, rather, the mayor should use the money differently. Maybe it's better to really, for example, encourage people to walk in the cities if you have benches, for example. The mayor can do this. So what is most efficient, really, what to do this for the long term, for different health to avoid these risk factors as much as possible, to be how can we have more efficient policies? Thank you so much, and see you very soon with great pleasure.